Good morning, everyone. Good morning, everyone.
Good
Good
morning.
morning, sir.
Myself,
Morning,
Dr.
sir.
DM Gupta, President UPUP. I
Yes, sir. We
welcome you
called
all.
upon you.
A very good morning to all of you. Welcome, Dr. Shah,
Very
Dr.
warm.
Arun Dwivedi, Dr. Secretary, sir, and our guest lecturer for the day.
Uh, Dr. Shad is the master of ceremonies. Please continue.
Actually, Dr. Munish ma'am is busy with some exams. Yesterday already she has informed. I will be unavailable and Dr. Shad will look after of the entire program. Dr. Shah,
Sir, I'm there.
Yeah, please
uh,
start.
I think
Should we start, sir?
Please start, sir. We are short of time.
Okay, so we are starting our program. Good morning to all. This has really been a wonderful session on pediatric cardiology, and I welcome you all to a pediatric cardiology e-learning module. After really a phenomenal beginning where we had a fabulous session on art of history taking, we now move forward to our next topic, which is examining a child with heart disease. Is it different from the usual approach? And the speaker of this session is Dr. B.R.J. Kannan, sir, from Madurai, while chairpersons are Dr. R.N. Dwivedi, sir, a very senior pediatrician and president-elect for UPIAP from Agra. And we had another very senior pediatric cardiologist, Dr. Ishita Banerjee from Prayagraj, who will be joining soon. And okay, so I would request everybody to really Tapan to look forward and mute all rest of the people who are not speaking, so that we
Yeah,
don't
I'm
have
looking
that.
for that. I'm looking for that.
And we are really fortunate to have Dr. Vineet Saxena, sir, who's a past secretary, Central IIP, and a very senior pediatrician from Mirror. So now I would now request Dr. D.N. Gupta, sir, President UPAOP, to kindly formally introduce the speaker and welcome everybody for this program. Dr. D.N. Gupta, sir.
I will welcome on the part of UPUP. The rest of introduction will be given by the chairperson, Dr. Arun Dwivedi sir and Dr. Ishita. And once again, it is a second part of the e-cardiology learning classes, which are going on since last month. We have a very good start. We have a lot of attendees at the moment. In the past two, near about, we have 125 registrations so far. And with such a innovative idea from Dr. Munish Tomar, we are marching ahead in the academic field, and with the cooperation of each and every office bearer of the UPOP, the things are going and smoothly in the right way. And as per our goal, we are moving in that direction only. Without wasting much time, I welcome our today's speaker, along with the chairperson, along with the master of ceremony, and from on the behalf of all the office bearers of the UP, I welcome you all the attendees for being with us. And over to the chairpersons, Dr. R. N. Dwivedi, sir.
Thank you, sir. Thank you, sir. It's a matter of pride and privilege to have such an astounding faculty on board who will be sharing us about the examining the child with the congenital heart diseases with cardiac problems. So Dr. B.R.J. Kannan is a very renowned pediatric and cardiologist. Currently, he is the director and senior interventional cardiologist at Badalan Hospital, Madurai. He did his DM from Sri Chitra Tirunal Institute of Medical Sciences and Technology, Thiruvananthapuram. And then he did his fellowship in pediatric cardiology from Amrita Institute of Medical Sciences, Kochi. Then he did his fellowship, Commonwealth Fellowship in interventional cardiology from the Guyas and St. Thomas Trust Hospital, London. He, to his credit, has more than 30 publications in journals of national and international repute. He has contributed to more than 12 chapters in various books and more than 300 lectures and sessions in various academic activities. Currently, he is also the proctor for various intervention cardiology procedures. So I welcome Dr. B.R.J. Kannan to address his deliberation. Welcome, sir.
Thank you, sir. Thank you very much for the
So
introduction.
just I would utilizing this opportunity to give an informal introduction of Kannan sir. That Kannan sir is being besides a very eminent pediatric cardiologist, is a very phenomenal teacher. We at Amrita were really fortunate to listen to his lectures. He makes the topic so simple and have such a command over all the aspects of pediatric cardiology, especially hemodynamics and arrhythmias management. So we are looking forward to have a wonderful session. And at this juncture, I will take the liberty of permission from your side that we will be interrupting you in between the lectures for make it more interactive. So
Sure.
yeah. So thank you, sir, for being here.
Right. In fact, before starting my talk, this will be my way of introducing myself. Let this not be a classroom kind of discussion. Let this be very, very informal. Aim is none of the slide. See, the slide should not move to the other next slide unless the previous slide has been understood by everyone. It's not important how many slides I am presenting. It's important how many slides that I presented has reached the audience. So let us go in this same way. Anybody can feel free to interrupt at any point of the time. We'll clear the doubts and then move on to the next slide. And even if it is going to be the repeat question, still it is welcome. Getting repeated and the doubt getting clarified is much better than going with not true meaning or half truth meaning.
Yes, sir. So in that point, I will request all the participants to put their queries in the chat box, and I will be discussing that queries with the sir in between the lectures.
Yes, what will happen on the course of lecture? You get some doubt. You think of you will think you will ask the doubt later at the end of the lecture. At the end of the lecture, you would have forgotten your query. So in the chat box, then and there you can put down your queries and we'll address it later. Okay. So with this introduction, can I start my lecture?
Sure, sir.
Yeah, thank you very much. Thank you, Dr. Monish and everyone for inviting me for this forum. And so the topic is examining a child with congenital heart disease. Now, this topic, whatever you're going to hear, is going to be slightly unconventional, but that is what the aim of this meeting is. Heart diseases in children, most of the serious congenital heart diseases present in the neonatal period and early infancy. Most of them have no murmur or only a very short, soft murmur. Many of them mimic respiratory disease or sepsis. And the conventional textbook description of cardiovascular evaluation is possible only in older children. Okay. So the agenda of my presentation is, I'm going to give a practical approach, not necessarily from the point of exam. The initial part of the lecture will be unconventional. I'll be dealing how to go with age-oriented approach, understanding the physiology of congenital heart diseases, specific features of some congenital heart diseases. Later part, I'll go to the conventional cardiovascular examination. This later part can be found in any book. So even if I miss some of the slides of the later part, doesn't matter. But I'll go slow with the initial part so that every one of you understands how I approach a child with suspected heart disease in my OPD clinic. So the diagnostic approach would be first and foremost age-oriented approach. So who is the child? How old is the child? Is the child is a neonate or child is in early and mid infancy or late infancy? First and foremost, what is the age? Because the diseases which are presenting in various ages differ. Depending on the disease, depending on the presentation, I should expect the history, I should expect the clinical finding. So it's not like, you won't go, you try to find out all the findings, then try to come out with some diagnosis. Before reaching the child itself, I should have some diagnosis in mind. That's what I'm going to try to say. So in neonates and infants, we'll have a physiological diagnosis rather than anatomical diagnosis. I'll come to that later. In older children, proper anatomical diagnosis can be judged clinically. So in neonates, we are coming to the neonates. Neonate 3-day-old, 5-day-old, 7-day-old. As I said, if you want to make a difference in the field of pediatric cardiology for all the pediatricians, for that matter, if you are going to depend on mom, or if you are going to depend on a child of 1 year, 2 year old, that means nearly 70% of serious congenital diseases, treatable congenital diseases have been missed. So our concentration should be predominantly on neonates and the first 3 or 4 months of the infancy. You should not miss a single child. So what are the diseases in the neonates? First is duct-dependent lesions. It's duct-dependent pulmonary circulation or duct-dependent systemic circulation. Transposition of great arteries, total anomalous pulmonary venous drainage, especially obstructed type, and admixture lesions. Very rarely, large PDA, AP window, truncus arteriosus, all can present in the neonatal period. All these terms, this duct-dependent pulmonary circulation, duct-dependent systemic circulation, are self-explanatory. It may sound like high-sounding words, but they are actually self-explanatory, simple terms. I'll explain it. So what is duct-dependent pulmonary circulation? Now, see, this is the normal circulation. RA-RV, blood enters the pulmonary artery, goes to the lungs, comes to the LA, LV, and aorta. Now, here there is pulmonary arteries here. There is no flow going from the right ventricle to the pulmonary artery. Then how does the blood goes into the pulmonary artery? Through the patent ductus arteriosus. So because of the patent ductus arteriosus, the aortic blood enters the lungs, and that blood which goes into the lungs gets oxygenated. Okay. But what happens around 3 to 4 days time? The PDA suddenly shuts off. The PDA closes off. The PDA closes off, there will be discontinuity between the pulmonary ventricle and the pulmonary artery. And no blood will flow into the lungs. And child typically present at 24 to 72 hours with severe sudden onset cyanosis. So the clinical feature of all these individuals, see the underlying condition could be anything. It could be single ventricle, it could be tricuspid atresia, anything. There is pulmonary atresia, there is severe pulmonary stenosis. The pulmonary circulation depends on the patent ductus arteriosus. All these things come under the topic called duct-dependent pulmonary circulation. So here, there will be development of cyanosis, which will be rapid, and rapid worsening will be there. There will be single second sound, highly unremarkable otherwise, child will be sick looking and acidotic, and this kind of child who presents on day 4, day 5, day 6 will be misdiagnosed as sepsis very commonly. So there comes the importance of detection of cyanosis. Clinically, we will not be able to appreciate cyanosis many times. So we have to depend on the pulse oximeter. All of us know that cyanosis is apparent only in less than 75 or 70 many times. But book says less than 95. But many times we have missed the saturation of 75 also to be detected clinically. So we should not go by our clinical acumen to diagnose desaturation or cyanosis. We also use the pulse oximeter. Any value less than 95% subnormal after 48 hours of birth. So pulse oximetry is an invaluable tool in our clinical diagnosis. Now, the initial slides I said duct-dependent pulmonary circulation. Now, what is duct-dependent systemic circulation? The initial part of the disease was in the right heart. Now the disease is in the left heart. There is mitral atresia, or there is hypoplastic left ventricle, or there is ascending arteries, very, very thin, and aortic atresia is there. So the left ventricle is non-functional, and the blood is not going through the ascending aorta to the systemic circulation. Now, the pulmonary artery will support the systemic circulation through the patent ductus arteriosus. The earlier example, aorta was supporting the pulmonary artery through the patent ductus arteriosus. Now, the pulmonary artery will be supporting the descending aorta through the patent ductus arteriosus. So this is called duct-dependent systemic circulation. So there will be obstruction to the left heart outflow, as I have said. Circulation is maintained through the PDA with the right to left shunt. And when the PDA constricts, suddenly the systemic left will be compromised, and hence the child will present like a shock-like state. See, this is called interruption of aorta. Okay, this condition is called interruption of aortic arch. The descending aortic blood is entirely dependent on the patent ductus arteriosus. Now imagine when the PDA constricts, suddenly there will be no flow to the descending aorta. So it's like the patient child will present like a shock-like state, and there will be pulse disparity. Again, single second sound, no murmur. So in the previous examples, whatever I have shown, which is a very big chunk of cases of pediatric cardiology, relatively well child, presenting dramatically between 2 days to 1 week of life with cyanosis or shock, strongly suggests duct-dependent lesion. It could be duct-dependent pulmonary circulation or duct-dependent systemic circulation. There need not be any clinical feature to suggest any heart disease. Then how do I judge that there could be congenital heart disease? This thought has to come into our mind. Like, see, I saw the child 3 days back. Now, 2 days later, 3 days back when I saw the child and discharge, child was so well, so normal, well, 3 kilo child, otherwise well-looking child, clinical findings were normal. Now within 2 days, the child has come in such a sick state. Can there be any serious infection in a term baby that causes so much of sickness in 2 days of time? It won't. So in the neonatal period, whenever a child comes with any sick status, and if the sick status cannot be explained easily by any other secondary cause, think of cardiac cause. The moment you think of cardiac cause, we're going to read the X-ray much more in a better way. We're going to ask for an echo. And if echo rules out heart disease, that's fine. You might be suspecting congenital heart disease in a neonate 19 times. 19 times it may not be a congenital heart disease. But the 100th time it will be actual congenital heart disease, which will be correctable and you will save that child. Okay. So we should not fear of or we should not worry of asking the echocardiogram because nowadays it's very easily available. Even bedside echo can be easily done. And we should not miss any serious congenital heart disease in the neonatal period. Now, what are the other diseases in the neonatal period? Transposition of great arteries. Again, the child will have a single second zone at a short murmur or murmur may not be appreciable. Again, obstructed TAPVC. Child will have a single second zone or variable second zone. Again, a short murmur at the pulmonary artery. So what I'm trying to emphasize is that murmur is not a problem of any of these children, whereas cyanosis is an important, very important feature of all these individuals, all these children. So how do we screen these children for congenital heart disease? We do clinical examination and pulse oximetry pre-discharge on third or fourth day of discharge of the child and repeat the same at 68 weeks. Suppose we have done a proper oximetry pre-discharge, it was normal. And then we are doing another oximetry at 68 weeks, that is also normal. We practically rule out all cyanotic congenital heart disease. We will not be ruling out acyanotic heart disease, but we will be ruling out cyanotic congenital heart disease. So if anyone is abnormal, either the basal pulse oximeter was abnormal or the repeat pulse oximeter was abnormal, then in that case, we should ask for an echo and pediatric cardiology evaluation. So this is for the children who are presenting in the neonatal and early infancy. So how do we identify heart disease in a neonate? I'm going to look for desaturation or cyanosis. I'm going to look for a shock-like state. And if these things are there, I'm going to seriously suspect congenital heart disease. The usual cardiac findings are conspicuous by their absence. We have to remember this. Okay. Now, what about the heart disease in infants? So this duct-dependent lesions are all gone. They would have presented by neonatal period or at the earliest by 6 weeks or 8 weeks. Whereas in the infancy, the common presentations are from the left to right shunts, admixture physiology, top physiology, and other miscellaneous lesions like valvular heart disease, obstructive disease, and cardiomyopathies. Now, I'm going to take you into the so-called physiological approach. Again, it might sound a bit high, but it is not. It's very, very simple. When we approach a heart disease in infant, we should have a functional approach or physiological approach. Ask two questions. Is there a cyanosis or systemic desaturation? Is the pulmonary blood flow is normal or increased? That's all. If you can answer these two questions, that is there a systemic desaturation or is the pulmonary blood flow normal or increased? Then you can put the child into one of the category and thereafter you can further fine-tune our diagnosis. Now, let us take, I'm just asking this question. In left to right shunts, the symptoms depend on the degree of the shunt. How many of you agree? Maybe you can tell the answer by yourself in your mind. In left to right shunts, the symptoms depend on the degree of the shunt. Is this statement true or false? Actually, it is partially true. Okay. Now, this is the way we assess the pulmonary blood flow. You see, there was a session on history. Definitely, you would have history. You would have asked the features of increased pulmonary blood flow. Clinically, whenever a child comes this kind of protruded chest and subcostal retractions, it's a very clear-cut indication that child is in heart failure. This can occur with respiratory disease also. But when you are not suspecting respiratory disease, when you are suspecting cardiac disease, this finding is a protruded chest, visible pericardial activity, and subcostal retraction strongly suggests that there is increased pulmonary blood flow. Okay, so let us just initially start with the post-tricuspid shunt. So in the post-tricuspid shunt, the commonest shunt we know is large ventricular septal defect. Okay, now coming to physiology. See the left ventricular pressure, say 90 in that newborn or the 2-month-old child. If the left ventricular pressure is 90, because of the large communication, the right ventricular pressure also will be 90. Okay, agreed? Left ventricular pressure is 90, right ventricular pressure also is 90. Because right ventricular pressure is 90, pulmonary artery pressure also will be 90. Okay, so aortic pressure also will be 90. So the systolic pressure of all these four chambers, I mean, do two chambers and two great vessels will be 90 same. See, you commonly would have heard that a large VST, if you don't operate, it will develop pulmonary hypertension. There is no question of developing pulmonary hypertension. These children post tricuspid stents are born with severe pulmonary hypertension. You know, it's simple physics. Simple physics. Left ventricle is 90, right ventricle has to be 90. So both ventricles are of same pressure and both great arteries have same systolic pressure. What's the difference? The diastolic pressure in the pulmonary artery will be low. The diastolic pressure of the aorta will be high. So the pulmonary vascular resistance will be low. Systemic vascular resistance will be high. So the blood will tend from high resistance zone to the low resistance zone. That's why the left to right shunt is occurring. So the left to right shunt in post tricuspid shunt is because of the difference in the vascular resistance and not just because of the difference in the pressure. The pressures are same. So a large VST is by default a case of severe pulmonary hypertension, whether it's 3-month-old child, 3-year-old child, or 30-year-old man. If there's a large VST, if there's a large AP window, there'll be severe pulmonary hypertension. So what are the other examples other than VST? Complete aortic canal defect, PDA, aortic pulmonary window, all of them will have large left right shunts and pulmonary hypertension. Now let us take ASD. ASD is also having increased pulmonary blood flow, isn't it? I am saying this is an example of 3-month-old child. 3-month-old child, large ASD and increased pulmonary blood flow. There is no cyanosis, okay? There is volume overload, RA and RV are enlarged, lungs are receiving lot of blood, say 3:1. Here also lungs receive lot of blood to the tune of 3:1 shunt, okay? Here also lungs are receiving lot of blood to the tune of 3:1 shunt. But what's the difference? Here, the ventricles were interconnected and hence PA pressure was very much elevated. Here, the PA pressure is normal. In the newborn period, there could be some increase in pulmonary hypertension or pulmonary pressure. Over the period of 5 days to 7 days, the PA pressure will fall. By 1 to 1.5 months, the RVH will regress, the RA pressure will fall, and the left to right shunt will start occurring. By 3 to 4 months, there will be significant left to right shunt across the ASD. So a large ASD, which was not having any murmur in the newborn period or the first 6 weeks to 8 weeks, in the 3rd month or 4th month, will have a good murmur in the pulmonary area. At times, the parents even may accuse us. What, doctor? We have been showing our child for several days or several months. You never told about heart diseases. Now, suddenly in the 5th month and 6th month, you are telling there is a heart disease. Like that. So, the reason is this. In ASC, the flow will not occur in the first 1 to 2 months. Once the flow starts occurring, the murmur will appear. Now, in spite of having 3:1 shunt, this child is not having any symptom. Why? There is no pulmonary hypertension. Okay, because the internal septum is intact, the original PA pressure has regressed to normalcy, so this child remains asymptomatic. So the answer to my previous question, is the symptom determined by the degree of left to right shunt? Only partly. If it is only volume overload, like in this case of ASD, there is left to right shunt of 3:1 shunt, but in spite of that, child is asymptomatic. On the other hand, if it is a post tricuspid shunt, say VSD, AP window, or PDA, if there is left to right shunt, there is volume and pressure overload, and the patient becomes symptomatic. So it is the pressure overload which makes the child symptomatic, and not just the volume of the blood entering the lungs. What about admixture physiology? I'm just going back to the same previous slide. Now here I showed a large VST. Okay, large VST, I'm showing a left to right shunt. There is increased pulmonary blood flow. We all understood. There is all pure left to right shunt, and there is no systemic desaturation. There is no cyanosis. Now, in the same person, suppose if I remove the entire interventricular septum, it becomes a single ventricle, isn't it? If I remove the entire interventricular septum, the image will look like this. Now, the pulmonary venous blood also comes here. The systemic venous blood also comes here. They mix together. As I explained earlier, lung has a low resistance. The pulmonary vascular resistance is low. Aorta has a high resistance. Systemic vascular resistance is high. The overall, the pulmonary blood flow is very much increased. This child also will have a pulmonary blood flow of 2 to 3:1. The large VST child also had a pulmonary blood flow of 3:1. This child also will have a pulmonary blood flow of 3:1. Now, what's the difference? Now, here, the desaturated blood came to the ventricle. the saturated blood came to the ventricle, they mixed up. Because of the mixing up, the saturation of the blood in the ventricle will not be more than 95, it will be less than 95. It may be 93, 92, or 90, like that. That mildly desaturated blood enters the pulmonary artery and aorta. Now here, predominantly it is left right shunt. There is some right-left shunt occurring because of this admixture. That's the term called admixture physiology. So in admixture physiology, the pulmonary blood flow is increased. There's mild systemic desaturation. Clinically, we will not be able to detect the cyanosis. And hence, I have not written cyanosis. I have written as desaturation. The desaturation will be mild. There won't be any cyanosis. This you will detect only when you put the probe on the and check for the by the pulse oximeter. The saturation may be 80, 90, 92, like that. It may not be more than 95, but it will be like that. These are the examples. Tricuspid side, VST, mitral side, VST, developed right ventricle. All these are examples. So what is admixture physiology? He will have clinical features like a large VST, large post-tricuspid shunt, but there will be systemic desaturation. Got the point? Very simple. When there are features of increased pulmonary blood flow, child is failing to thrive, weight gain is not there, poor suckling cycles are there, child cries incessantly. When you examine, child has intercostal and subcostal retractions. Okay, clinically there is a soft ejection murmur, and saturation is 98. So he is VSD, for example, he is VSD. The same child, same presentation, all same examination findings. When put a probe, the saturation is 90. That means it's not simple left to right shunt like a large VST. That could be a single ventricle, that could be a TAPVC, or that could be a tricuspid atresia. Okay, that's the difference. Okay, so admixture physiology is where the both desaturated blood of systemic return and the saturated blood of pulmonary venous return mix up, and then the mixed up blood enters the pulmonary artery in the aorta. Okay, now let us come to the same thing. I have put in a cartoon kind of, it's for easy understanding. You can see that the blue blood, red blood mixes up, becomes a violet blood, and the blood goes to the pulmonary artery and the aorta. Okay, these are the examples of tricuspid atresia. This is a single ventricle as an example of the previous. Now, what is TOF physiology? So the same, let us come to the same large ventricle. See that? So I started with the large ventricle. Again, I am remaining with the large ventricle to explain all these three physiologies. Very, very important physiologies. Now, here there is a large VST. Again, the right ventricle pressure and left ventricle pressures are same. But now here, the blood flow into the lungs is prevented by the presence of the pulmonary stenosis. The pulmonary stenosis could be subvalvular, that is infundibular. It could be annular, it could be valvular, or it could be supravalvular, or it could be any of the combination of these things. So the flow into the lung, the flow into the pulmonary artery is reduced by the presence of the pulmonary stenosis, which could be subvalvular, valvular, annular, or supravalvular. So the pulmonary blood flow is reduced here. In the previous two examples, the pulmonary blood flow is increased, where the degree of pulmonary blood flow increase was dependent on the pulmonary vascular resistance, which was much low. Now here, the pulmonary vascular resistance is low, but before that there is RVOT resistance. There is mechanical RVOT resistance. The PVR is normal in patients with TOF. If you go into the PA and measure the PA pressure is going to be normal. But the resistance is at this level. RVOT resistance, the mechanical resistance. So when the left ventricle contracts, the left ventricle has two places to go, blood, either the aorta or the pulmonary artery. When the right ventricle contracts, the right ventricle also has two places to go, either pulmonary artery or the aorta, depending on the relative resistance between the SVR, that is systemic vascular resistance, versus RVOT resistance. When the RVOT resistance is more right left occurs, shall be deeply cyanosed. When the RVOT resistance is lesser, good amount of blood will go into the lungs and shall be less cyanosed. Okay, so now you have understood TOF physiology. In TOF physiology, when the desaturated blood comes to the right ventricle and the right ventricle contracts, the blood ejected from the right ventricle has two pathways, one into the lungs, one into the aorta. The entry into the lungs depends on the RVOT resistance. The entry into the aorta depends on the systemic vascular resistance. And depending on the degree of pulmonary blood flow, there will be systemic desaturation. So here, if the child is having increased pulmonary blood flow, decreased pulmonary blood flow, decreased pulmonary blood flow. What about sinus? Significant sinuses is there. Okay. So all these are other examples. For the single ventricle has PS, if there is a DORV with PS, if it is tricuspid atresia with restrictive VST or PS, all will behave similarly. That is clinically, when you have a TOF-like picture clinically by your clinical examination, the underlying echo diagnosis need not be exactly TOF. It could be TOF like other conditions also, like the single ventricle PS, devolved PS, or tricuspid atresia. All these things also can present. Now, so I have discussed three basic physiologies. Hope you all have grasped what I have said. I am repeating the same thing repeatedly because if this goes into the mind, you'll be able to diagnose most of the heart diseases in the children. That's what I am doing in the OP clinic. Do you think in the OP I am diagnosing single ventricle in a child? Do you think in the OP after examination I am saying this child is having common air canal defect? No. I will diagnose this child probably as a post tricuspid increased permanent blood flow, probably a VSD, probably AP window. If there is murmur of PDA, then I say probably PDA. No. So, or I'll say this child has severe cyanosis and precardium is very quiet. I think this some kind of TOF is there. This could be classical TOF or some other TOF-like situation. Like that, I also diagnose. So now let us come. Again, I'm repeating. There are three basic physiologies. In left to right shunt, child is pink, child is having heart failure. No doubt. In left to right shunts, child is pink, child is having heart failure. In right to left shunt, child is blue, there is no heart failure. Here there is heart failure, there is no heart failure. This is tetralogy of failure, this is VST. In between the two, we have a situation where there is a lot of left to right shunt, but some right to left shunt causing admixture. Child is pink, there is heart failure, but the desaturation is there, which can be detected only by pulse oximetry. Okay, so these are three groups of children who present around the 1.5, 2 months, 3 months, and things like that. Okay, now same thing. I'm again coming back again. How do I approach a child with suspected congenital heart disease clinical examination wise? First, I'll see no cyanosis, no desaturation. Then I look at the child, and after my clinical evaluation, I think the child is having heart failure. There is hyperactive pericardium. Pericardium is pulsatile, and I am also able to hear some murmur. That could be ejection murmur or MDM or whatever it is. Child has no desaturation. Child has features of heart failure. So it fits into simple left to right channel. Usually it's going to be a post tricuspid channel. Okay, on the other hand, child has significant cyanosis. Okay, child has no failure. Pericardium is quiet. Quiet means not sound, I'm saying. Pericardium is not active. There is no pulsation. Pericardium is flat. There is no increased pericardial activity. So this combination very much fits into tetralogy of failure physiology. These are the two extremes. And in between the two, I said, there is mild cyanosis, or rather the word cyanosis, I use mild desaturation. Child has all the features of heart failure and hyperactive pericardium. So this fits into the diagnosis of admixture physiology. So very simple. Okay. So let us have this in mind. And once we have clinically diagnosed, see, if you find a child fitting into these three mild cyanosis, features of failure and probable admission physiology, you can write in the referral letter, this child based on my assessment, saturation 90%, there is feature of heart failure, probably Cori admixture physiology. That's all I'm going to diagnose in clinically also. Subsequent diagnosis comes only by echocardiogram. Okay, so my diagnosis in my OP is no way different from your diagnosis in your OP if you approach in the same way what I have told so far. Now, what about other heart diseases? Now, let us take another child who has only prominent murmur. Child has no cyanosis, no failure, no active pericardium, only murmur. So these are the children who have come for murmur for evaluation. Asymptomatic murmur, only murmur is there. These are the children who may be having small post-tricuspid stents like small PDA or small to moderate PDA, small VST. ASD, as I discussed earlier, even large ASDs may not be having any symptom. They may have murmur, but otherwise child will be asymptomatic. All valvular heart diseases, AS, PS, MR, unless they are very severe, causing ventricular dilatation and failure, which is a very late event. Before that, before these children developing those symptoms, most of the time we pick up. We are not going to pick up for the first time a child with aortic stenosis coming with LV dysfunction and heart failure. We are not going to pick up a child with pulmonary stenosis who has developed such a severe pulmonary stenosis, developing RV failure and heart failure. Similarly, we are not going to diagnose first time MR with heart failure, except in acute rheumatic fever, is MEPMR or whatever it is. We'll be diagnosing these murmurs much earlier when the child is under our follow-up. So when the child has presented only with prominent murmur, without any cyanosis, heart failure, and no atypical cardium. This is what we are going to think. What I'm saying is, unless you think like this and then approach a child, you will easily locate the diagnosis. Otherwise, you will miss. That's the importance of making up our mind. What's the problem underlying the diagnosis, and then going for the clinical examination. Okay. And then this last group also very, very important. Here, the other way, prominent murmur, no failure, nothing is there, asymptomatic murmur. Now here, child has all the features of failure, but practically no murmur at all. In the previous case, I said, no, here, child has all the features of heart failure, but there's a prominent murmur. Okay, no cyanosis. Whenever there is a murmur, even the murmur is not prominent, but some soft ejection murmur is generally present, that points to left atrium. When you have a similar child, who is 3-month-old child, who has features of hyperactive pericardium, who is in heart failure, but he doesn't have murmur. This combination is very much suggestive of cardiomyopathies. Okay. And if you follow this, you'll be able to pick up myocarditis, cardiomyopathy, Alcapa, tachycardiomyopathy. All these things will come under this category, where the child will have features of heart failure, but no. Okay. So see, I put some 5 boxes now. 1, 2, 3, okay, this 4 and 5. So most of the children, almost all the diagnoses will fit into one of these 5 categories where I have put into. And if we repeatedly go through this and practice, we will be able to diagnose most of the children with congenital disease. And to some extent, we practically nail the diagnosis also clinically before that. So again, to simplify, acyanotic child, active chest and murmur is left to right shunt. Acyanotic child, active chest, no murmur is cardiomyopathy. Cyanotic child with active chest is admixture physiology. Cyanotic child and quiet chest is top physiology. Prominent murmur, no failure in quiet chest is ASD, small post-expectance, valvular and etc. 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 Okay, so got the point. See, in older children, what are the diseases that are possible? In the asymptomatic category, we have moderate to small VSD, small PDA, PES, AS, RSD, and cardiomyopathies. Older children beyond 6 months. What I have discussed in the neonatal period in the first 6 months, as I told in the beginning, if at all you want to make a change in the outcome of pediatric cardiology, you should be diagnosing a lot of congenital diseases less than 6 months. So beyond 6 months, these are the acyanotic diagnosis. In the cyanotic possibilities, it's Fallot's variants, Epstein's anomaly, Eisenmenger syndrome, pulmonary fistula, systemic venous flow to LD, etc. Okay, just to list the things, I have put it up. So, age, history, general appearance of the child would tell us what's the probable lesion or what group of lesion is possible at this age. With this background, when you go on further kind of, examine the child, most of the time you'll be able to properly guess the possible underlying congenital diseases. Okay, I think I'll stop here for maybe 1 or 2 minutes before I go to the conventional other discussions. Maybe if there are any doubts, I can clarify. Hope I am clear what I have been telling so far. I just repeated the same thing so many times. I want to ensure that each one of you, whoever have listened, is very clear what I have been telling so far. I'll just wait for 1 or 2 minutes for any doubts. Is there any chat box? Is there any doubts?
So far there are no questions in the chat box.
Right.
Just making, because there are postgraduates there in this program. So where we will fit in the transposition and DAPVCs in this approach?
At the initial in the neonatal period, again I say in the neonatal period, sudden dramatic presentation is generally a drug-dependent lesion. In the same time, most important tool will be to diagnose the pulse oximeter desaturation. You have a child where there is increased pericardial activity. There is even mild subcardial retraction indicating that pulmonary blood flow is normal to high. Whenever the pulmonary blood flow is normal or slightly increased, what do you expect the systemic saturation? Systemic saturation has to be normal or only mildly reduced. But here, there will be severe desaturation. On one side, clinically, you will have features suggestive of normal pulmonary blood flow or increased pulmonary blood flow. But systemic saturation will be 50, 55, 60 like that, because the systemic iota is coming from the right ventricle because of the transposition of the right arteries. So whenever there is a discordance between pulmonary blood flow and the systemic desaturation, that favors transposition of great arteries. Okay. In admixture physiology, there will be features of increased pulmonary blood flow, but mild desaturation. There is features of increased pulmonary blood flow, but severe desaturation, then that is TGA physiology. There is severe desaturation, but features of decreased pulmonary blood flow becomes TOP physiology. Again, TAPVC also, there is no specific clinical clue. Basically, child will have features of increased pulmonary blood flow and desaturation. That's all. But seconds will be very widely split or well heard split. These are very soft points. Many times clinically, we also may not be able to diagnose because of the tachycardia. But in neonatal period, whenever you have features of relatively increased precordial activity and significant desaturation, we should think of these two conditions like a transposition of great arteries or obstructed TAPVC. Non-obstructed TAPVC will present slightly later, 1 or 2 months later, but obstructed TAPVC can present in the neonatal period.
So yeah, both of these are like critical congenital heart disease really present very early in neonatal period. So Anitha, what I have been seeing that these postgraduates are gets very confused about the obstructed and non-obstructed. So can you elaborate them a little bit?
Okay. See, even when I was doing my MD pediatrics, I was told the commonest cause of heart failure in the first 1 week of life is hypoplastic left heart syndrome. It's not correct. Whatever we have discussed, they don't cause heart failure. They will cause only severe cyanosis and shock-like state. So it's a desaturation which is leading us to the diagnosis rather than the features of heart failure. Whenever we say TAPVC, all the pulmonary veins, they are supposed to drain into the left atrium. Instead of draining into the left atrium, it drains somewhere else, either in the right atrium or in the SVC or in the IVC. That's called anomalous, total anomalous pulmonary venous connection. Now, when this anomalous connection is there, for example, all the pulmonary veins are draining into the innominate vein, or all the pulmonary veins are forming a common chamber draining into right atrium. But if there is a large AST, the blood will mix up in the right atrium and come to the left atrium, left ventricle, and into the aorta. So the systemic flow is not compromised, and the child will be relatively asymptomatic. There is unobstructed TAPVC. What do you mean by obstruction? There is a flow for the pulmonary venous blood to enter into the heart. For example, in supracardiac TAPVC, there is a vertical vein which drains the pulmonary venous blood into the innominate vein. If the vertical vein is obstructed by the pulmonary artery pressure or by some other means, the pulmonary venous flow cannot freely enter into the innominate vein. So the pulmonary venous pressure will be very high. There will be severe pulmonary hypertension. Suppose if there is coronary sinus kind of TAPVC, and if the coronary sinus ostium is stenosed, where it enters the right atrium, the pulmonary venous pressure will increase. Okay. In all infracardiac TAPVCs, the infracardiac TAPVC, the blood enters into the IVC. Not directly into the IVC, it goes to the portal vein. When the blood enters the portal vein, it has to go into the liver sinusoids and then come back to the IVC. So there is inherently severe obstruction in the form of capillaries. Okay. So all infracardiac TAPVCs which are draining into the portal vein are by default obstructed TAPVCs. All infracardiac TAPVCs are by default obstructed TAPVCs. Supracardiac TAPVCs, majority are unobstructed. Some of them can be having obstruction. So whenever there is obstruction for the blood pulmonary venous flow to come back into the heart, then that child will have severe pulmonary hypertension, will present early. Whenever there is no obstruction, they can present later. So that's how we call it obstructed and unobstructed.
Yes, thanks a lot. And sir, keeping the discussion more forward, where we put patients with severe obstructive, like right side obstructive lesions and left side obstruction, like severe PS.
Valvular lesions.
Yes, critical PS and critical PS.
Exactly. Good that you are bringing out this point. The critical PS in the newborn period is generally rarer. And whenever there is a critical PS in the newborn period, rather than presenting as right heart failure, most of them will have tricuspid regurgitation, most of them will have PFO, they will present with severe cyanosis. Again, they will present as a cyanotic heart disease. Most of the children with critical PS will present as a cyanotic heart disease rather than right heart failure. Whereas critical AS or critical coarctation of aorta they'll present with heart failure and as left heart failure. So a critical EAS or critical coarctation can present like a shock-like state and left heart failure, whereas a critical PS most of the time will present as cyanotic heart disease, not like a heart failure individual. So that's the difference. Clinically, there will be prominent murmur, and depending on our judgment and subsequent echo, both of them need very urgent treatment, and both of them can have a discrete coarctation can have a transcatheter treatment, otherwise a arch coarctation needs surgery. Whereas for bicuspid aortic valve related aortic stenosis, many a times will be palliatively, we will be doing the balloon valvotomy to improve the child's condition. That's the difference.
Thank you, sir. Thanks a lot. So if you have no more questions, you can still move forward, sir.
Yeah. So again, I'm repeating this aspect. See, this PowerPoint is going to be available with you in the YouTube. I request every one of you to go through what we have discussed so far, and to approach the child in this kind of physiological approach, so that you'll be able to point out what heart disease the child is having. Okay. Now with this, let us go to the routine
I would
evaluation.
encourage all the participants to please write their queries in the chat box so we can have a more interactive one session with the sir.
Okay. So this is a routine thing. So where we are going to look for anthropometry. As you know, there'll be failure to thrive, poor growth, heart failure, and cyanotic heart disease. How do we evaluate a child with failure to thrive was one of the common questions during my period. I don't know how now. Why now? Now, when a child is not growing, there is failure to thrive, and if the child is having underlying congenital heart disease, the congenital heart disease will not be clinically silent. Whenever clinically you have examined and you have done some basic investigations and echo, your saturation are normal, it is very less likely that a clinically silent congenital heart disease is producing failure to thrive. Most of the failure to thrive causing congenital heart disease is clinically evident. It could be either severe cyanotic congenital heart disease or it could be failure. Heart failure will be diagnosed clinically. Obviously, cyanosis will be diagnosed by pulse oximeter. So we'll be able to pick up. Like tall stature is a feature of Marfan syndrome, short stature is a feature of Noonan syndrome. Now, before even going to the child, before even trying to put our hands for the pulse, the first look, is there any dysmorphic faces? As we know, Down syndrome is associated with endocardial crescent defect or AV canal defect, and also VST. Even they can have tetralogy of Faro also. Noonan syndrome, very commonly pulmonary stenosis. In Noonan syndrome, there is peculiarly, they do have hypertrophic cardiomyopathy, biventricular hypertrophic cardiomyopathy. Even both sides, it could be obstructive also. Commonly, hypertrophic cardiomyopathy is seen on the left side, left ventricle more than right ventricle, and obstruction also more common than right. But in children, biventricular is common. In Noonan syndrome is one situation where it could be biventricular and it could be RV obstruction also. Marfans can have MEP and aortic regurgitation. Turner syndrome, AS, coarctation of aorta and ASD. Polteram syndrome, ostium primum ASD. Williams syndrome, supravalvular AS. As you know, initially, when you join the MD in the first year, when somebody says, see, this is a Down syndrome child, you will try to see how the eyes are there, how the nose is there, what about the overall face, and try to see whether it's a Down syndrome. But after some 5, 6 children you have seen the Down syndrome, thereafter, the moment a child with Down syndrome is seen by you, you immediately diagnose. No? It's like reading ECG. Your brain registers the features of Down syndrome, and you need not calculate or you need not kind of fix up the diagnosis. It tells you the diagnosis. Similarly, all these things, Noonan syndrome or Marfan or Holter, William, once you see a couple of patients, immediately your brain will say, oh, this is William basis, like that. See, this is Down syndrome. Okay, the medial canthai are downwards. If it is reverse, the medial canthai are upwards, it's Noonan syndrome. Okay, there's also hypertelorism. This Williams syndrome, I don't know how exactly to describe. If you see a couple of children with Williams syndrome, you will be able to diagnose Williams syndrome. Children refer to me as bicuspid aortic valve EAS. The moment they were entering into my room itself, I was diagnosed in some last week that it looked like Williams going to be more like a supravalvular AS, and it was a supravalvular AS, and it was a Williams syndrome. So Turner syndrome, the webbed neck is very easily identifiable. Like, this is CAS22 phases, slightly difficult. Slightly difficult. Once you repeatedly see, maybe you'll be able to see this conotruncal anomaly related phases. Polterm will have limb anomalies. is another example of Williams syndrome. So this difform feature is very important. They are not common, but when they are present, they tells us what will be the underlying congenital disease. Okay, so we should look for pallor, look for edema. Lower limb edema is somehow rarer in children. Edema suggests right ventricular failure or biventricular, congestive heart failure. It is rarer in younger children. Clubbing is suggestive of cyanotic heart disease or infective endocarditis. We should look for chest deformities. We should look for kyphoscoliosis, especially in older children. Whenever there is desaturation for a long time, most of the time you can see some degree of kyphoscoliosis in older children, which is very common. Doesn't lead to any diagnosis. It's a feature of cyanotic heart disease. Obviously, rheumatic nodules. I have seen at least some 5-6 cases of rheumatic nodules in this past 30 years of my cardiology practice. But I wonder whether any of you, the new residents, will be seeing this rheumatic nodules. It's very, even rheumatic fever itself is rare in the private practice nowadays. So this is just deformities, what we see in Marfan syndrome. Okay, we don't know the exact reason of chest deformities, and there is no relation with the kind of deformity and the underlying heart disease. Okay, but these deformities are in favor that this patient probably having collagen problem and probably having Marfan syndrome. So we'll spend some time on pulse, very important. See, it is expected that we should look for the pulse for the 1 full minute, but which is not practical. Whereas pulse oximetry is a very good substitute. Even in my OP, when I will be busy looking for some other patient, my staff kind of goes to the child sits on the lap of the mother, puts the pulse oximeter the leg or the hand, wait for it to have a very stable curves, very stable pulses, then records the saturation and the pulse rate. And that is very quite accurate. The pulse oximeter recorded heart rate is reasonably accurate. I have diagnosed bradycardia many times. When we examine clinically, we very commonly diagnose tachycardia very easily, but we miss the bradycardia many times. I have diagnosed bradycardia, the bradycardia which I missed clinically have been diagnosed by pulse oximeter. So it's a good, I think, it's a routine that all my children, even when they're coming for the follow-up, I am putting the children on pulse oximeter not because I want to detect more and more cyanosis, because of the accuracy of diagnosing pulse rate. So the irregular pulse rate is not common in children. The commonest cause of irregularity is sinus arrhythmia, atrial ectopics, ventricular ectopics, and atrial fibrillation. Atrial fibrillation is very rare in children, except in the newborn period. Tachycardia could be myocarditis, heart failure, and arrhythmias. Bradycardia could be sixth-sinus syndrome and complete heart block. And complete heart block is not that rare, and sixth-sinus syndrome is also not that rare. So we should be able to diagnose these things by simply looking at the pulse rate. If it is a large volume pulse, it indicates or it might indicate underlying aortic incompetence, retinitis arteriosus, peripheral fistula or anemia. With small volume, heart failure, pericardial effusion, and coarctation. In coarctation, the lower limb pulses are not palpable. The lower limb pulses are not palpable not because the lower limb is not getting any blood. Lower limb is getting the blood. Lower limb pulse is present. If you put the catheter into the femoral artery and measure the pressure may come as 80, 85, 90. Then why are we not palpating the lower limb pulse in coarctation? It's because it's non-pulsatile flow. There is a collateral related continuous flow into the femoral artery. The pulsation is not that much. The pulse pressure, that's the difference in the systolic and diastolic is very small, and hence we are not able to feel the pulsations. For us to feel the pulsation, there should be good gap between the systolic and the diastolic pressure. That's the pulse pressure should be high. Higher the pulse pressure, we'll feel it as large volume. Smaller the pulse pressure, we'll feel it as a small volume. In coarctation of aorta is very small, and we are not able to feel any pulse at all. But there is flow into the legs with reasonably good perfusion. So what is pulse deficit? It's the difference in the heart rate and the pulse rate when counted simultaneously for 1 minute. It is seen in atrial fibrillation, and also the child is having multiple BPCs will have pulse deficit. Radial delay, that is right pulse is better, left pulse is left, radial pulse is kind of weaker. That is seen in patients with supraorbital aortic stenosis and pre-circulating coarctation of aorta. Radiofemoral delay, that is upper limb pulses are normal, lower limb pulses are weaker. That is seen in post-ductal coarctation of aorta or the middle aortic syndrome. So blood pressure measurement is again slightly difficult in our routine OP practice. Ideally, we should have at least 3 cuffs, if not 4 cuffs. And ideally, machine measured blood pressure is much more accurate than hand measured blood pressure. Okay, so many of them may be having, as I said, even for pulse measurement, I'm recommending pulse oximeter. Similarly, if you want to be very accurate about your blood pressure measurement, we should be using we are measuring the blood pressure using the machines rather than by your mechanical using a diaphragm using for the correct of sounds. So JVP is enough if you see whether it's elevated, normal, or collapsed. Trying to see whether A wave or C wave, the descents, everything is very difficult, and that is again common in older children, and it's rarity. If it is elevated, how much is elevated? Again, not very important. If it is elevated, means patient is in heart failure. That's all. Okay, especially right heart failure is there. So if it's elevated, normal, or collapsed, the small sign is during inspiration you expect the JP to come down. On the other hand, during inspiration, if the JP increases further, jugular venous pulse increases further, that's called small sign. Inspirate increase in the jugular venous pulse. That is seen in cardiac tamponade, constrictive pericarditis, and RV failure. Hepatojugular reflux simply means there is severe tricuspid regurgitation. That is, you compress on the liver, hold the compressed in the right hypochondrial space for some time. A JP which was normal will become very prominent because you are pumping in all the blood from the liver into the IVC that goes to the SVC instead of going to the right ventricle because of severe TR. Okay. So whenever you examine the child, try to look for the scars which will indicate previous surgeries in that child. Like midline scar could be a previous palliative procedure, like say central shunt. This could be a surgery for coarctation of aorta, or if there is anteroatrial thoracotomy, this could be because of the previous whatever mitral repair or maybe aortic closure or whatever. So if there are scars, please make a note of the scar and write it down. What about visual pulsations? Visual pulsations means a dilated heart, usually a volume overloaded heart. Suprasternal pulsations are seen in aortic regurgitation and coarctation of aorta. PA pulsations, left second intercostal space, seen in pulmonary hypertension. Epigastric pulsations are seen because of the right ventricle enlargement, liver enlargement, and abdominal aortic pulsations. Apical area pulsations because of LV dilatation, and pulsations over back is because of the coarctation of aorta. Palpation. See, this one, I don't know, undergraduate itself, they should have told you. When you try to look for the pulsations, use the tips of the fingers. When you're trying to look for the thrill, use the base of the fingers. This place where the thrills are very well felt. And whenever you want to see the, for heaves, RV heave, you use the base of the hand or the ulnar aspect of the hand. So apical impulse, what is apical impulse? Lowermost and outermost point of definite cardiac impulse is the apical impulse. And it is not like in adults. This is in adults. In adults and older children, it is fifth intercostal space, medial to the midclavicular line. Sorry, it's not medical, medial to the midclavicular line. Whereas in infants, it is in the fourth space. In the till about 3 to 4 years, it is in the fifth space at the midclavicular line. It comes to the adult like medial to the midclavicular line only after 5 years. You should see whether it's a LV type or RV type. If it's a diffuse kind of apex where you are not able to exactly say where it is, this is more like an RV apex. Again, this RV apex, LV apex, and all only in older children, 4 or 5 year old. Younger than that, we will not be able to clearly tell. Like, for example, is a 3-month-old child with a large VHT. The LV will be enlarged, but you won't have a very localized LV kind of apex. You can have a diffuse kind of apex. So this differentiation of RV, LV, everything is only for all. In fact, many of these so-called cardiac examination findings are more pertinent to the older children, not in younger children. And once you comment about apex, you should say the normal apex, tapping apex, hypodynamic, and heaving. By hypodynamic, you mean it is a volume overloaded ventricle. Heaving, you mean it is pressure overloaded ventricle. For example, patient is having aortic stenosis. Here, for example, patient is having mitral regurgitation. Okay. And a parasternal heave, that's a palpable parasternal thrust that lifts the hand that indicates that RV is dilated and under pressure. This also can occur with the inlay enlargement, but it's very rare. For completion's sake, I have written here. Whenever you have parasternal thrust, by all practical means, it is RV is dilated and under pressure. These are the useful grades which we all know. So S1 is loud in high output states and mitral stenosis. It's soft in mitral regurgitation and calcified valve. Kindly don't comment on split of S1. Clinically is not possible. T1 is very soft. The S1 T1 gap is very small, and hence we will not be able to appreciate split S1. So just S1 only. And whenever you say S1, you are trying to say only mitral M1, and hence your description is based on what you hear at the mitral area. I have seen people describing S1 in the pulmonary area, S1 in the tricuspid area, S1 S2 normal in the aortic area. No, that makes no sense. Heart sounds means only you have to tell in toto, not related to the area. Only the murmur you have to relate to the area and say what murmur is the pulmonary artery, what murmur is the tricuspid area, and things like that. Okay, sounds in general. So S1. S2 needs some more kind of listening and some more information is available from the S2. Is it normally split? Okay. If it is normally split, what about A2 and P2? P2 is normal, means pulmonary hypertension is not there. P2 is loud, means there is pulmonary hypertension. P2 is soft or absent, means there is pulmonary stenosis. Whenever there is pulmonary stenosis, either there is soft or absent. If it is loud, means there is severe or there is pulmonary hypertension. If it is wide split second sound, in case it is wide split, we have to see whether it is fixed split or variable split. It's not very difficult. In the older children, if you keenly listen, you will be able to say whether it is fixed or variable. Reverse split is seen in severe AS and LV. This is difficult. When we are not clinically so well versed to diagnose reverse split and all, again for completion's sake, I'm writing here. Whereas wide split, fixed and variable can be diagnosed clinically very easily. I'll just give you this is normal. During inspiration, there is the two sounds widely apart, but during expression they come together. So when you hear it in expression also, that is when you are able to hear the split A to P2 in expression also, then that is really wide. But in inspiration is wider, in expression is less wide. This is called wide and variable. In both inspiration and expression, the width is the same. The A to P2 gap is same both in inspiration and expression. That is called wide and fixed. This is wide and variable. The most common reason for wide and fixed split is ASD. So all other reasons are generally for wide and variable causes. Okay. Paradoxical split, when the LV, RV is much more delayed. So when the RV occurs earlier than LV, higher paradoxical split. And when both SVR and PVR are together, it will become a single second sound. For example, large VST with descending syndrome. SVR and PVR are almost the same. So we have single second sound. In tetralogy of Fallot, the PS is not at all here. Pulmonary sound is not at all here. So it will become a single second sound. So single second sound could be fusion of A to P2 or disappearance of P2. There is nothing called disappearance of A2. So single second sound could be disappearance of P2 or fusion of A2 and P2. So additional sounds we should comment: opening snap, ejection click, mid-systolic click, and multiple clicks in Epstein's anomaly. Just yesterday, I was very happy that one of the pediatricians referred me a case of a short systolic murmur is able to hear at the apex. But actually, it was not short systolic murmur, it was a mid-systolic click. It was a mid-systolic click. So, murmurs and thrills, these are the various long description of murmur. I'm not going to go into that. But this one slide is very important, just please note. In large VST, we'll have an ejection murmur in the pulmonary area and mid-diastolic murmur in the mitral area. In small VST, there will be pansystolic murmur. That's all. Nothing else will be there. In large AST, like here, there is ejection murmur in the pulmonary area, whereas MDM at the tricuspid area. Small AST, short or no murmur. This for the AST and VST. Very small PDA, no murmur, only soft systolic murmur will be there. Yeah, small PDA, say around 2 to 3 millimeter, will have a soft continuous murmur. A moderate to large PDA will have loud continuous murmur. When very large PDA is there, only systolic murmur is here. Because there is diastolic equalization or there is no turbulence in the diastolic flow, you will not hear the diastolic murmur at all. So in very large PDA, you will have only systolic murmur, but a loud murmur, and with clinical features of increased pulmonary blood flow. In very small PDA, again only systolic murmur with no features of increased pulmonary blood flow. So again, these are the classical causes of pansystolic murmur, BST, MR, and TR. ESM at pulmonary area depending on the pulmonary blood flow. So whenever there is ejection systolic murmur in the pulmonary, it indicates pulmonary stenosis. In patients with long ESM, there is good pulmonary blood flow, the child will be pink. Whenever there is severe RV outflow obstruction for the flow, there is short ESM, which will be blue. During the period of silent expel, there won't be any RV murmur. So this is regarding the ESM in the pulmonary area. ESM in the aortic area is suggest your aortic stenosis. Okay. Again, early diastolic murmur, mid diastolic murmur, these are the usual causes. Early diastolic murmur in the aortic area, we should suspect about bicuspid aortic and truncus arteriosus. Whereas early diastolic murmur in the left parasternal area, which is very easily here, is due to absent pulmonary syndrome or severe pulmonary hypertension. These are the MDM which I have already discussed. So continuous murmur causes, if the child is asymptomatic and continuous murmur, it is because of the PDA, peripheral PS, and coarctation of aorta. Child is cyanotic and continuous member is pulmonary fistula, pulmonary atresia with the PDA, and some surgical decisions. So these are the descriptions about murmur. So to summarize, what I'm trying to emphasize is that we should go with understanding of the physiology. So physiological or first let's go to the age-oriented approach. What is the age of the child? What is the probable underlying heart disease I'm expecting in this child? And what about his so far history tells me? So let us create an idea, then approach the child. So in the neonatal period, cyanosis or shock-like status indicates drug-dependent lesion. Severe cyanosis and active precardium indicates TG and TAPVC. In infancy, the approach is based on the systemic desaturation pulmonary blood flow. And then we classify them into left to right physiology, admixture physiology, top physiology, and others. In the others, AST, small VST, cardiomyopathy, and other things will come. Okay. And most of the children will fit into one of these things. And older children, again, valvular and obstructive diseases are much more common. Then small to moderate stents. And 95 to 98% of cyanotic heart disease in older children will be of top physiology. May not be the classical top physiology. Understanding the hemodynamics helps in speculating the underlying congenital disease, which in turn aids in proper clinical examination. This is my ultimate message of this presentation. Thank you very much for the patience. Thank you.
Thank you. Thank you so much, Dr. Kannan, sir. This is Dr. Ishita. It was an illustrative presentation, and it was indeed a pleasure listening to you, sir. Break up an apparently very difficult topic into simplified blocks for easy clinical approach. Today, there is an easy accessibility to echocardiogram for a quick diagnosis, but a strong clinical suspicion of the underlying hemodynamics or underlying physiology is definitely of utmost importance. And whether it is purely cyanotic or purely in heart failure, or the child has features of both, with or without murmur, that the way you have divided them into the different blocks is definitely, it will definitely help the PG students, I'm sure. And also, I think while doing a clinical examination of a child, and inspection becomes equally important, if not more, than auscultation, because we are able to pick up so many things just by looking at the child. And final suggestion to the PG students who are listening: one must commit to a clinical diagnosis before picking up the echocardiogram probe. Thank you once again, Dr. Kannan. Thank you so much for a beautiful presentation.
Thank you.
So could we take up some questions?
Yes.
Yeah, so actually there have been some query regarding which machines we are using for pulse oximetry and for blood pressure monitoring. And because there have been a lot of variability with, especially if they are recording multiple times, there's been quite a variability of the blood pressure measurement. So what you recommend for measuring the pulse oximetry and blood pressure?
I'm not sure. I don't know what machine we are using.
Actually,
I think one has to use some standard. Most of the standard machines are good, and if it is giving a error, you can discard and get some other machine. I'm not a good person to really tell the technicality of this one.
Yeah,
but all the machines, they do not give you a wrong reading for the rate. The problem is with the saturation measurement. So whenever in doubt, you re-measure the saturation measurement. Maybe you are in a better position to comment regarding the machine.
Yeah,
Sir, we are not
if I may interject there.
Dr. Shah?
Yeah. So what we are recommending is using all the pulse oximetry which are based on Massimo's
Yes,
technique.
sir. We are more concerned with the technology rather than the machine or company. Is the Massimo technology is better, or some other technology which we are using earlier? Is there any difference between the two, and how it is different from the previous one?
So actually, the Massimo ones has been well standardized, and you get a good tracings across. Once you put a probe across a baby, you get a proper tracings and all. So it is a bit expensive. The one which we are using, the finger probe one, sometimes get the erroneous reading, especially if the tracings are not being clear. So what we teach our postgraduates that, especially where you have to wait for some time to get better proper tracings, and then comment on what the level of saturation you're getting.
Yeah,
So, but
exactly. Unless there is a very steady pulse seen, when I presented also, I told you, the staff waits for a standard or stable pulse. Only then see records. The stable pulse reading by the machine is very crucial for us to believe on the numbers what it gives. So this Massimo technology or something else, I'm not very sure, but I don't know what we are using. But we have been happy with the machines, whatever our institution has got us. Other questions regarding the?
So it's, I think most 3-4 questions are related to this only. So so far no further questions. Yeah, I would request the participants kindly put your questions as fast as possible.
Any open question or open comment? I mean,
Hmm.
was the presentation different than what you expected? If someone can comment on that.
So it was an, may I take the opportunity?
Yes.
Yeah, please.
It was an altogether different presentation, like classifying things into very complicated things into two very simple manner, understanding the physiology and then going for the proper clinical examination. So understanding the physiology makes things very simple. On the right
Yes.
side, left side, duct dependency on the right, pulmonary circulation, then classifying things into the 5 boxes. So that is a very systematic approach, and at least it gives us some clue to the diagnosis when we see the patient clinically. Later on, the confirmation by the echocardiograph and all
Exactly.
machine dependencies are there, but clinical acumen is developed only by this first part of your presentation.
Exactly.
So thank you for this.
Yes, sir. Thank you.
I think
Sir,
Dr.
if I
Ishita
may
can
add,
Yeah, please
yeah,
go
if I
ahead.
can add to that, sir, I would like to say that after listening to the first part, the second part was it
More
seems
theoretical. Yeah.
we need not adhere to the conventional kind of an approach,
Yes.
because
Yeah.
it is this clinical to understand the physiology is so much more important.
Yes. Yeah. And moreover, subsequently, in subsequent weeks, we are going to have approach to synaptic AS, and again, we are going to repeat. But
Yeah.
this initial part, if it is there in all of your minds, the subsequent
Right, sir.
lectures will become very meaningful.
Right, sir.
Why we are interviewing, why we are not interviewing, everything will be very meaningful.
Yeah, so that's why ma'am decided about to get with best of the teachers to start with the basic topics. Raghavan sir started with the art of street taking, and so now you have taken up this examination part so diligently. So thanks a lot, sir. If anyone want to comment, sir?
Dr. Saad, one thing I would like to add that already, madam, in consultation with us, we have decided all the topics. The basic purpose we are our key persons who are attending this program are the postgraduates and the practicing pediatricians. Unless until we start from the basics, we are not able to reach to the top of the building. So unless हमने जब तक अपने जो है नींव का नहीं मालूम होगा, then we are unable to understand the rest of the things which are going in the middle of the learning. So
Yes,
that's why we have put the anatomy first, then we have come with that this history taking, followed by this examination portion. This is a basic part of this our module. And we have, and for the sir very rightly presented today's topic, sir, unless until we don't have the basic physiology, we are unable to hemodynamics, we are not going to understand. And already I am a graduate from the